welcome to today's ERA Journal Club. My name is Kate Stevens and I'm based in Glasgow in the United Kingdom. And along with my colleague, Dr. Jennifer Lees, also based in Glasgow, we will be moderating today's session. So today we're discussing a CKJ paper. And this is a historic ERA Journal Club because it is the first as a women editor of CKJ, so Prof. Maria Soler. So the paper we're discussing is entitled "A Prediction Model with Lifestyle Factors Improves the Predictive Ability for Renal Replacement Therapy in a Cohort of almost 500,000 Asian adults." And we have first author Min-Kuang Tsai, along with his co-author Wen Ko, who will be presenting the paper and their findings. And on the panel, we have Dr. Navdeep Tangri, who is an associate professor in nephrology based in Canada at Manitoba University. And we have Dr. Morgan Grams, who is a professor of nephrology, recently moved from the Johns Hopkins in Baltimore to New York City. And both our panelists are experts in epidemiology. So without further ado, I'll hand over to Dr. Min-Kuang, who will give us a presentation about the paper.
My name is Tsai Min-Kuang from National Taiwan University. Here sitting next to me is Professor Wen Gao from Taipei Medical University. I would like to thank my co-authors, including Professor Jian Guolong, Professor Xu Zicheng, and Professor Wen Qibang. My research title is "A Prediction Model with Lifestyle Factors Improves the Predictive Ability for Renal Replacement Therapy." We use a large cohort with 500,000 people and use this data to develop a prediction model for kidney dialysis. Taiwan has the world's highest dialysis incidence rate. Taiwan's population is about 23 million, about 1/3 of the UK population of 67 million. But Taiwan's dialysis population is 3 times that of UK. Taiwan has the dialysis population of more than 90,000, which is about 3 times the UK dialysis population. Taiwan's implementation of national health insurance in 1995 completely removed patients' financial barriers to renal replacement therapy. As a result, the numbers of dialysis patients as well as healthcare expenditures for renal replacement therapy have increased dramatically. We want to know why continuous increase in dialysis, especially if some lifestyle factors are relevant to the increase of dialysis. There are many prediction models for kidney dialysis, but the most common used is the kidney failure risk equation developed by Professor Tangri in 2011. This KFRE formula can achieve more than 90% prediction accuracy of dialysis with a few simple variables. In particular, the KFRE model has also been externally validated in more than 30 different countries. This model has also been constantly evolving from 3 variables, 4 variables to 8 variables, and now it even becomes a dynamic model. I think for these details, we would like to learn more from Professor Tangri. The strength of KFRE model is that it can use simple 4 variables, including age, gender, eGFR, and albumin creatinine ratio. This prediction can achieve more than 90% predictive power. This formula has also been externally validated and is currently used in many countries. In the UK NICE guidelines, based on the KFRE model, if the dialysis risk exceeds 5% within 5 years, it can be used as the criteria for patient's referral. There are also models that incorporate different clinical examination variables. The vast majority of current dialysis prediction models are based on CKD stage 3 to 5, that is their eGFR below 60. So we are thinking whether it is possible to focus on general population at lower or no CKD risk. Modified Lifestyles such as maintaining weight and engaging physical activities can reduce the risk of renal failure. Consequently, we expect to reduce the disease burden. And Professor Grimes published prediction kidney donation candidate in the general population through nearly 5 million people from 7 different cohorts, including the United States, Canada, Israel, and other countries. The follow-up time varies from 4 to 16 years to predicting people's lifetime risk of dialysis. And Professor Grimes' predictions mainly include eGFR, urinary ACR, systolic blood pressure, antihypertensive drugs, diabetes mellitus, body mass index, and smoking status. And the predictive power ranged from 70% to 90%. So we are thinking in Taiwan, a country with such a high instance of kidney dialysis, in our cohort is almost 0.5%, which is much higher than other countries. Is there an opportunity to develop a model for predicting dialysis based on East Asian ethnic groups? In addition to KFRE variables, we also included lifestyle risk factors and common screen variables to develop a model for general population. We try to identify those at high risk of disease for primary prevention. Our cohort participants went through health screenings. We analyzed data from their first visit. By linking this cohort to the dialysis registry, there is a 21-year follow-up with a median follow-up of 13 years. We can find those people who were on long-term dialysis. Our approach is to incorporate all cohort participants into the prediction model for dialysis. The validation we used is internal validation. We randomly divided the cohort into 2 halves. We verify our model with half of the participants. The total number of cohort is about 500,000. After following up for 13 years, the total number of RRT was about 2,000. We used Harris Index to evaluate the performance of the prediction models. We showed the sensitivity and specificity for the total cohort for our prediction models. We set the optimal cutoff point by using the maximizing the Youden index. We also used the 10 years RRT risk exceeding 3% as a reference standard for RT high risk in this general population. We created scores based on the weighted sum of the identified predictors in each model, with the weights based on coefficients from the multivariate cost regression model. We included age, sex, eGFR, and dipstick proteinuria in our model. The predictive performance is about 91%. By adding smoking status, physical activity, BMI, resting heart rate, diabetes and hypertension history, and educational levels, the C statistics increased to 94%. And in our full model, which included 10 more clinical checkup variables, the C statistics increased further, improved to 95%. To access the goodness of fit of the models, we calculated Harris Index for all 3 models in the full, in health training and validation data sets. For those with CKD stage 1 to 5 in our cohort, the C statistic was slightly lower compared with the total cohort for model 1. For participants without chronic kidney disease, the C statistic for model 2 and model 3 was 83% and 87% respectively. The calibration plots for RRT instance per 1,000 person years for 10-year RRT risk were shown in the upper three figures. The discriminatory accuracy of the models in lower three figures also showed that adding lifestyle and medical history and other clinical health checkup variables can improve the predictive accuracy for dialysis. In our cohort, about 9.3% have CKD stage 1 to 5. Among those who have had dialysis at the end, they have CKD stage 1 to 5 in their initial visit was about 70%. But of those who ended up on dialysis, 85% were in our model as high-risk individuals as optimal cutoff points. In fact, the proportion for higher-risk individuals a score 22 or above is similar to the proportion of CKD stage 1 to 5, but we found more participants who had dialysis in the end. So again, we present those who had dialysis in our cohort in this table. About 70% dialysis participants can be found with CKD stage 1 to 5, but by using our ideal cutoff point, that is those with a score 22 or more, reach 85%. Of all 2,000 participants who were on dialysis, we found that 369 participants, or 17 of the dialysis patients, did not have CKD at the time of entering the cohort. These people are considered to be at high risk of dialysis according to our model, but their eGFR was greater than 60, and their urine proteinuria was negative. We found that these participants were relatively younger, had a higher prevalence of diabetes, 82% versus 43%, and engaged in poor lifestyle habits like smoking, lack of physical activity, and higher resting heart rate compared with those who have having CKD. We think that our model can be used for general population and consider the patient with the eGFR of 40 and 1+ proteinuria. The risk of RRT in 10 years would be 3%. Hypothetically, RRT risk for individuals without a history of hypertension or diabetes and lifestyle risks, the predictive risk of RRT was 0.39%, even with the kidney function progressed to 40. Professor Grant recently published another article in the New England Journal Medicine Journal, mainly emphasizing the importance of eGFR and albuminuria. But in our model, we believe that if lifestyle and health history can be added to eGFR and proteinuria, so that the risk of kidney dialysis within 10 years can be better predictive. But the disadvantages of this model is that we include more variables, actually total 21 variables in our full model. But if there are only 4 variables similar to KFRE, plus 7 additional variables such as educational levels, smoking status, physical activity, body mass index, resting heart rate, hypertension medication, and diabetes medication, we think this can be used for general population. In our cohort, we found more than half of those who ended up on dialysis are among those who 10-year dialysis risk we predict exceeds 3%. So finally, I would like to conclude by highlighting that our prediction model, including medical history and lifestyle factors, improved the predictive accuracy for RRT in this large heterogeneous cohort representing general population. I would like to thank all advisors who guided me. Actually, I just passed my doctoral dissertation oral exam last week. I also want to thank reviewers for their valuable comments. Because of your help, this research can reach more people. I would also like to take this opportunity to thank Professor Tangri and Professor Graham for their participation. I've been greatly inspired by you since I was doing my research. It makes me feel like I'm standing on the shoulders of giants working on this topic. There are still many shortcomings in my research, but I hope you continue support by reviewing and advising me on research works. We also hope that our model can be externally validated, especially the inclusion of health history and lifestyle habits. Thank you.
That's super. Thank you very much, Dr. Tsai, for the presentation. And just while we close those slides down and get back onto the discussion screen, I would like to say congratulations to you on behalf of the ERA Journal Club team for the recent success in passing your doctoral oral exam. Very well done. So we'll start the discussion now. We have had some questions submitted ahead of time by email, but this is just a reminder that participants can submit questions during the session via the Q&A function. We'll get to as many of these as we can, but apologies in advance, we may not be able to answer them all. So moving on to the discussion, there were two kind of broad themes that I was hoping to touch on. So the first was on simplicity versus accuracy for an individual equation. And the second was looking at the same kind of thing, simplicity versus accuracy across populations or generalizability of these equations. So hoping that we can come back to both of these themes at one stage. So my first question is for Dr. Tsai. So in a general population setting, you seem to be very fortunate in Taiwan that you've been able to collect all of this information on lifestyle factors, including physical activity, including education status. But it looked like in the paper, you had something like 42,000 out of a total of 400,000 of people who had complete cases. First of all, have I got that correct? And second of all, how well did your model perform when some of these variables were missing?
On that was a typo, but I'm not sure.
Okay. It seemed a very small number with complete cases from what you'd said, so I maybe misunderstood that. So I suppose my kind of follow-on question to that is, in populations where we cannot necessarily capture all of these additional details, do you think this is generalizable to these other populations, or how would we go about collecting that information to use that in this type of equation?
We developed this model from a large screening cohort. So we think maybe this model can be applied to general population after they go to screening health checkups.
But we also understand that it is not easy to collect such amount of health data. But on the other hand, we know that nowadays we have a lot of digital health wearable devices. So collecting a lot of individual variables probably will be more likely and less costly over time. And I understand that it might be a trade-off between simplicity and predictive power. But I wouldn't say fortunately, since we have very high dialysis rate, in a way, we want our work to be educational by including health lifestyle risk factor, and shows maybe just a little bit improvement of predictive ability, and to encourage people to reduce their unhealthy lifestyle. And I think that's one of the main motive of our study.
Yeah.
Okay. Thanks, Prof. Tangri.
So first, congratulations on this excellent study. My question was about, walk me a little bit, because I'm not familiar with the National Health Survey. Tell me, what is the sequence of events that happens with screenings? So let's say somebody, 400,000 adults show up, and then there are some abnormalities found. What happens? Do the results go to their family doctor? Do they go to a specialist? Like, what happens when something is abnormal?
This cohort is actually private enterprise.
Okay.
Participants join this membership health checkup enterprise, so it is a lifelong membership. So because these people are basically maybe more health concerns, they attend regular health checkup through this private enterprise, and we collect them and we follow them because they come literally every year. And then we link the final outcome to the National Dialysis Registry.
Yeah.
Yes.
I guess what I'm asking is, if I'm part of this cohort, and last year I had a normal screen, and this year I come and now my GFR is 50. What would be the actions that would be triggered under normal circumstances? What would happen?
In their health checkup, they will be recommended or referral to specialists, since it is the purpose of health and annual health checkup. So they will be referral to different specialists.
So one application of your model could be that for people who are in this checkup, they are referred to their specialist based on the score from your model, rather than on an individual variable that's collected in the model. Is that one of the possible applications?
Absolutely. Yeah. If they have higher risk of dialysis and they have different lifestyle habits, we can help them or ask them to quit smoking, do more physical activity, something like that.
Yeah. Yeah, no, I think maybe what I'm trying to get at, this will be my last comment, I want to let other great speakers here speak, is very important to think about risk to action. So what is happening today? Somebody has high risk. What's the new action? So what would you do differently? I think in all models, mine, yours, anybody's, we really have to be careful, say, what is happening today? Why is it a problem? And then if we get a better risk stratification tool, what different action would we take? So it sounds to me like in this case, the different action would be, if you're above a threshold for dialysis risk, you would be referred to a nephrologist, and maybe you would have education about lifestyle risk factors plus medication. Is that correct?
That's correct.
Yes, that's correct.
So I have a question for Prof. Grams. So all of these risk equations have incorporated albuminuria in some form. This equation is slightly different, and it uses dipstick albuminuria rather than an albumin to creatinine ratio, for example. But we know that the capture of albuminuria in many places, even amongst people with CKD, is still quite poor. Have you any thoughts on how we can improve albuminuria capture in order actually to be able to use many of these risk equations, even in their simplest form?
Yeah, I think great question. First of all, let me say congratulations for your PhD and this nice paper. I think the nice thing about this paper, which I'm excited about, is, so few cohorts have lifestyle in them. And so I think this really like drives home lifestyle is important, and that's something that you can change. And so that's a neat aspect of it. I think for anyone who has met Dr. Chipeng Wen, he is a testament to exercise himself, right? He's a very healthy ager. He gets up at 4 a.m. every morning to play tennis, I think. So we all love him at the CKD Prognosis Consortium. So congratulations. I think about the albuminuria. I think that is a great thing and something that I think Nav and I both feel very passionately about, that, you know, we need to be measuring albuminuria more often. And I think that, you know, yes, dipstick is not as good as a quantitative albumin to creatinine measure. However, if that's what you have, we can use it. And so we have equations that can convert it if you want to use it in the KFRE. It works very well there. We've shown that. And then, you know, they've shown also that the risk, the relative risk associated with the levels of qualitative dipstick is also very strong. Yeah, my favorite table of this whole paper, I think, was table S2. I just loved it. It was so good. It's so comprehensive, and it has some interesting risk factors there too. So I think that was neat. But I can talk more if you'd like.
Great, thanks. I'll let Kate ask her a question. She's had her hand up.
Yeah, thanks, Jen. So actually, I'm going to, I have a question I would like to ask you, and then there's a couple of questions in the chat that I'll put to you. So my question is really, it's a bit more practical. So I'm not an epidemiologist. So whilst the risk prediction is very interesting and it's extremely useful, it's a bit more about the action. So, I mean, I couldn't agree more with Prof. Grams about the fact that lifestyle is extremely important. And I think that, so certainly in the UK, it's not that we ignore it, but there's so much to deal with as a nephrologist that we spend all of our time prescribing pills for various different things, and then pills to fix the side effect from those pills, that we never have time to talk about diet and physical activity. We never really differentiate between physical activity and hardcore exercise, and not everybody wants to play tennis at 4 in the morning, although that sounds great. So I guess my question is, from a very practical clinician perspective, how do you see us actually translating this risk into proper action that's going to make a difference? So I'm going to I'll put it to our panelists first of all. So Nav, do you have a comment about that?
Yes, so I think this is really a great use of a health screening tool, especially, so I'm going to just focus on the population here. So very relevant. Sounds like these are people who volunteer. So they're already sort of health conscious people. So I think having a risk score then provides a real opportunity to tell them, hey, you've been flagged, you know, you did this screening and now you have a higher risk. Now here's some things you can do, because this risk is one, we're talking about a 10-year horizon in this paper. And two, this is a preventable disease. And, you know, you want to show up in future years to this exam having your risk be lowered. So I think it's a great opportunity to provide actionable feedback for people who volunteer for this type of intervention. I'm always a little bit of two minds on the nephrology side. Not that we shouldn't be promoting exercise and lifestyle risk factors in nephrology care, but unfortunately, we see like the very, very tip of the pyramid, like the bottom of the spectrum, when patients are already quite advanced. And we have an impact on really proximal outcomes, but from a big global health perspective, I think these types of screening initiatives, primary care policies, health policies that discourage smoking, improving physical activity are really needed to have the kind of national impact.
Yes, so I guess the thing is that for smoking, in most places there is a program, isn't there? So there's smoking cessation, but there's not the same thing in most places for physical activity and for diet, is there? And so I guess, so I'm not trying to be difficult, but I think that we really should focus on that. I think that we should really put far more into that. Prof. Grams, do you have a comment? You're nodding.
Are you talking to me? I'm sorry.
Yeah.
Yes, I think you're absolutely right. And I think, to argue a bit with Nav, we were just at international conference when a patient who was on a dialysis patient, spoke about his exercise regimen and how he goes to the gym 6 days a week and how he, and I do think that it also activates patients, right? Like you're giving them something that they can do themselves, which is super healthy. And I think getting oneself ready for transplant, or getting oneself at a healthy weight so that they could undergo transplant, all of those things, so it is relevant. My argument is it's relevant also within nephrology, and that we sometimes get a little lazy as doctors, I think, in saying, oh, we have to worry about your, I don't know, phosphate binder, and not make sure you walk around the block a bunch,
So I have a comment and then a question on a similar sort of thread. So the comment is actually from the chat from Cecile Cochou, who says, considering action, we need to be cautious that not having a risk factor at baseline is not the same as lowering the risk. And I guess what we mean by that is, if we take physical activity, for example, although we may have a risk predictor that will assess our risk of kidney failure in the future based on how much physical activity we say we do, we don't know that intervention necessarily will lower that risk. And so my question to Dr. Tsai and team is, if you have annual health checkups and annual screening, have you been able to look, or will you look at repeated measures? And if there are changes in physical activity status, smoking history, etc., will you be able to assess changes in those measures on the outcome of the kidney failure risk?
According to our repeated measurements, basically their health checkup, people's lifestyle seems to be quite persistent. People don't change their, like if they are physically inactive this year, next year, pretty much the same. So we haven't really done the change of all these factors associated with our outcomes. I think maybe this is our next step.
Yeah, because in this cohort, we use only their first checkup, their initial visit data. Yeah, of course, the lifestyle changes over time, but maybe we can incorporate some different their physical activity changes, their lifestyle changes to become a dynamic model, like Professor Tangri's model. Yeah, maybe this can further increase our prediction.
Yeah, that sounds interesting, and in keeping with calls to sort of introduce interventions to improve physical activity. I'll look out for that. Professor Grams.
Yeah, I was just going to say, I think, that comment was excellent. When we make these risk models, it's across people, it's not changes in people. And so I do think that, the application of risk scores section was a little bit of a stretch because no one is actually changing. However, there have been randomized controlled trials of this, right? Look ahead, where people made diet and exercise modifications that did help their kidney disease. So I don't think that we're, it's not the same thing as like hormone replacement therapy, and that, we just think it's good. I think we know that exercise is good.
Great, thanks. And I think Kate's picked up a couple of questions in the chat. Is that right, Kate?
Yeah, so just there's a question from Bernardo Marques da Silva. So this is to you, Dr. Tsai and Dr. Ko. Would you expect the same prediction capability in settings of lower dialysis incidence?
Was it to me or to?
Oh no, so you can have a turn in a second, but that's to the authors if that's okay.
Yeah.
So it's to author or to Professor Grams?
To the author. Okay. Do you want me to say it again, or you?
Can you repeat your question again? Sorry.
Of course. So it's from the audience. So wondering if you would expect to see the same prediction capability in your risk score if you had a population where there was lower incidence of dialysis.
I just don't know. I think this is an interesting question, and we are hoping that epidemiologists from other countries will be trying to do the same in their country where the incidence is lower, and that will be a validation. But since we only do single country study, so we are not sure that this will be the same.
Yeah, because this study is we only doing internal validation, not for external validation. But the lifestyle habits and medical history in our model too, we think these variables are similar to other prediction models for general population. So we hope that including medical history and lifestyle habits, and maybe can achieve similar predictive accuracy for other population. But right now we don't have data to say that.
Thank you. And
oh, sorry.
On you go, and then I have a follow-on. Carry on.
Okay, sure. So, you know, in the CKD Prognosis Consortium, obviously we've done this a ton, right? So I can tell you what my prediction would be. My prediction would be that the C statistic would be very good. The C statistic, if that's what your marker of predictive capability is, it's going to be very good, because all of the, as they said, the risk factors are very similar. You know, your relative risks are similar across settings. However, the calibration will be different, right? And we just see that over and over and over again. So, you know, everything, especially as you put in, this is sort of what you were getting at the beginning. I think as you put in more variables, your calibration actually can get even further off.
Yes.
And so the generalizability can vary quite a bit. And so we've seen, you know, with the KFRE, there's about a 2 to 3-fold variation in adjusted absolute risk. So I would guess there would be at least that here too.
And you have kind of introduced my question. So my question actually for Prof. Grams, Prof. Tangri was, should we have different kidney failure risk equations in different populations? I suppose this is the question of, do we keep it simple and have one for the whole world that's well calibrated in each area, or do we just accept that the risks are very different in different places?
I think one big factor that's clearly different is access to renal replacement therapy. So we can't ignore that. So, you know, I would say that in a country where there isn't universal access to renal replacement therapy, I would really model reaching eGFR less than 10 or less than 15 as the outcome, if I was to do an external validation or development. And I think that because of the differences in access to renal replacement therapy, I do think that if a country is deploying at a large scale, it may be worthwhile to do a regional check of calibration. Now, it may be that, you know, we provide two options in the kidney failure risk equation for non-North America and North America. That covers a lot of jurisdictions, but I would find it difficult to imagine that it covers places where there's virtually minimal access to renal replacement therapy. So I think local calibration efforts are important.
I would agree. And I think it all gets back to, what are you using the risk score for? So if you're using the risk score for referral for vascular access and you have no dialysis, then of course that makes no sense. And I do think, you know, it's very easy, at least for us, to check the calibration within a given cohort and recalibrate as needed. So if anyone wants to do that in their data, just ask us and we'll help you. Because we do know that, I think that the coefficients for the KFRE are very robust, but the adjusted baseline hazard can vary. And I think, you know, we even see that in North America. North America is a much higher risk than Europe. And why is that? It's because we are, I believe at least, perhaps we're a little bit more unhealthy, but also I think we're a little bit we're more eager to start dialysis in people, I think.
Okay, great, thanks. I'm going to change the topic slightly just so we can answer some of the questions that have been sent in by email previously. So this is a question for Dr. Tsai again. So first of all, how important is health literacy to the patient's outcomes? So one of your slides actually had, I think it was slide 18, had almost allocated a points-based system according to the different factors included. And it appeared that a college education, you got no additional points for risk of kidney failure, but if you were educated to below that level, you got a couple of extra points and were more likely. So can you comment on health literacy and educational status and how important that is compared to these other risk factors?
In our model, looks like health literacy education is a good predictor. They have, I think that's what we found, that by including these social demographic factors such as education level seems to improve the predictive power. Yes.
Yeah. We also found that those with lower health economic status or lower health educational levels, they have more chronic kidney disease than those with higher education. So we think social economic status is an important predictor to chronic kidney disease and RRT instance.
Okay. Were you trying to say something else just to check? No. Okay, that's fine. So now I have a more general question about use and implementation of KFRE. So in the UK, in the last year, KFRE has made it into our referral guidelines. So primary care physicians are now recommended to check KFRE and to make a referral to a nephrologist if we hit, in the UK, it's a 5-year, 5% risk of kidney failure. But speaking to people who work in primary care, general practitioners, there's really the knowledge and understanding of KFRE, that it's available and how to use it is very poor, at least is my kind of observed, that's the observed issue in Scotland and the UK. So I wondered if I could ask all of the authors and the panelists if they could comment on the use of KFRE in their local area, and if you have been able to implement it successfully, how have you done that? I'm going to start with Prof. Grams, if that's okay, because I know that this is an interest of yours.
Yeah, I think so. I liked the NICE guidelines. I thought they were really great and pushing the field forward. So congratulations on that. I think I have implemented it in the health record at Hopkins. It is currently only being used among nephrologists, not among primary care doctors. I recently moved to NYU, and now I'm trying to do kind of the reverse, doing it within primary care. I do have a huge amount of sympathy for primary care doctors because there is so much that they have to deal with in taking care of patients. And so I am a big believer in making things as simple and sort of as possible. So, one of the ideas is to have an automatic referral and that they can opt out of that happens in the background. Another one, in the same token as albuminuria testing, having opt-out albuminuria testing so that, people with an indication for albuminuria testing just get it ordered and the doctor can then uncheck it if they want to, but it's not an additional check for them to do. So those are sort of my thoughts.
Yeah, work in progress. Prof. Tangri?
So I think the implementation works best if it's integrated in lab information systems or electronic medical records. So Morgan's described a really great implementation in an electronic medical record. We've been trying to do some of that, but really trying to push it through the lab because EMR vendors are more difficult to deal with, in my opinion. So we've had one of the large labs in Ontario, Canada, fully report every time, and it's all triggered by urine ACR. So whenever a urine ACR is ordered, if the eGFR is less than 60, the lab reports the risk. And correspondingly and predictably, we actually see more urine ACR ordering, which is great because people like to see the predicted risk. We did sort of a communication to family physicians, and we're planning for a national rollout in Canada, virtually most of the large provinces this fall, as we switch the GFR estimating equation. So there's going to be a memo that has to go out to all physicians anyway for the GFR estimating equation. And the thought is that we'd also piggyback the KFRE in the lab report as a way to do that. And so hopefully I'll have more to report on how it turns out later this year and early next year.
Nav, can I ask a question on that one?
Sure.
So, we were just at this meeting and we were trying to push that as well in the US to, have our major lab organizations report it automatically, sort of like GFR. One of the big pushbacks was, patients are then going to see it and be super confused or nervous. So how did you address that issue?
Well, the one thing we found was that first, it's only reporting for people with, as you know, for people who already have established kidney disease. Now, they may or may not be aware, but they're already seeing an abnormal GFR and an abnormal ACR. And as you and I can both probably testify from clinical experience, that most of the time their expectation of their dialysis risk is a lot higher than what their KFRE risk is. So I think 9 out of 10 times, hopefully it'll be good news. So, but in nephrology practice, it's been really easy. Whenever we've done it, the feedback is always sort of very positive. This will be sort of more primary care to patients rollout. So it'll be interesting to see.
Okay, so we're almost at the top of the hour, so I think that we've had a fascinating discussion. That was a great presentation, so thank you very much to Dr. Tsai and Dr. Ko for that, and then thank you very much indeed to Dr. Tangri and Dr. Grams for joining us on the panel. When you end the session, you will see a short survey, and it'd be great if you could fill that in. It just takes a few seconds because it helps us to shape these sessions going forward and making sure that we give you what you are looking for. So thank you very much, everybody, and have a nice day or evening, depending where you are.